5 of our lectures on psychological disorders. In this particular section, we're going to talk about a unique psychological disorder referred to as schizophrenia, probably one that many of you heard mentioned in movies or TV. Oftentimes schizophrenics are portrayed to be, murdering serial killers, and yet the vast majority of them are, just people a little bit, off balance, but more or less harmless. Up in the right-hand corner up here, you see a very famous painting, Starry Night, painted by Vincent van Gogh back in 1889. The reason I selected this is Vincent van Gogh is often characterized as suffering from schizophrenia. However, we're going to see as we go through the lecture, actually Vincent van Gogh didn't. And what we're going to show you is how sometimes some behaviors that are caused by other things can be attributed to a wrong psychological disorder. Explain more as I go through. Okay, then. The gentleman you see down here in the lower left is Eugene Buehler, who back in 1908 was the first one to actually use the term schizophrenia. And so we say, give him credit with coining the term schizophrenia to refer to this disorder. Actually, his definition was very, very broad back in those days. And actually, he was looking at schizophrenia the way he defined it as being split mind. We have schizo, which means split. Phrenia, which means mind. He literally thought that in this order our mind split into two parts. And so he actually thought it was a special case or a type of what we refer to today as dissociative disorder or multiple personalities. However, over the years we learned that this disorder is very distinct and that that characteristic of split mind really doesn't hold up. But maybe they'll look more at it as using the term schizophrenia to refer to kind of a splitting off from reality. So let's take a look at the three major characteristics of schizophrenia. The first being disorganized and delusional thinking. When we start off here, here's an actual quote from a patient that she had. And it goes that, this morning when I was at Hillside, I was making a movie. I was surrounded by movie stars. I'm Mary Poppins. Is this room painted blue to get me upset? My grandmother died 4 weeks after my 18th birthday. Now, you wonder, my gosh, how many different thoughts are in this particular thing? I mean, the first few thoughts, all are linked together. And then, what's this thing about my room being painted blue and to upset me? And what does that have to do with my grandmother dying, particularly in relationship to me being Mary Poppins? And this is what happens in schizophrenia, and is one of the key characteristics of it. And we can see that in this particular monologue that we're looking at, this person, does have fragmented, bizarre thinking with distorted beliefs, which we refer to as delusions, such as I am Mary Poppins. And so delusion is a distorted belief that an individual has. You can also have other delusions, such as a very popular one is delusion of persecution, is where I think somebody is following me, somebody is out to get me, or the delusion of grandeur that I am the king. I am Jesus Christ. I am, Barack Obama, whatever, hero we have, or a powerful person. Somebody might go around impersonating Howard Hughes or somebody like that. And so, anyways, these are other types of delusions. Now, in going back to our quote up here, where we see a variety of different, kind of concepts or ideas all linked together in kind of a, short paragraph like this. This is what we sometimes refer to as word salad, or the more technical term is called clang disorder, clang being the individual who noted this characteristic of schizophrenia. And what we're going to see is what we believe is going on here is the schizophrenic lacks the ability to selectively attend to any thought for any extended period of time. And it's kind of like whatever thought pops into their mind, they go with it, and they can't stay with it though. So, they selectively tend to this, selectively tend to that, selectively tend to that one, without really running through the thoughts all the way. And therefore you get this, rather bizarre type of communication coming out of them. So we'll talk a little bit more about that in a little bit here. The second major characteristic is disturbed perceptions. And this is where it moves us into taking a look at hallucinations. Okay? And so schizophrenic, this is where we have sensory. The delusion refers to thoughts. The hallucinations refer to what we sense, and so frequently hallucinations are auditory, in the sense that we'll hear voices or things. To a lesser degree, we'll have visual. Somatosensory, we'll feel maybe bugs crawling all over us. Olfactory, where we smell smells where there isn't. Or we'll have tastes in our mouth, which are not, called for. There's no real basis for them. The biggest one is auditory, and you go down to, one of the parks downtown and see some of the people down there, kind of sitting on a bench talking to somebody, but there's nobody sitting alongside them, but they're having one heck of a conversation. Or maybe somebody standing on a street corner preaching to the masses, but there's nobody out there. I remember when I was going to Georgia State, and when I used to go down to Central City Park there by the trust company and that, there used to be a guy out there who'd be doing karate moves, fighting somebody, I don't know who, but he was having a heck of a time and getting a great workout, but he thought he was fighting somebody, and probably had one of those delusions of persecution to go along with an hallucination that the person was actually there and providing combat. And so those things are kind of common. And you look at the pictures here, and these are pictures drawn by schizophrenics. I mean, the eye at the end of the fingertip, but that's the way that they perceive things. And the other picture, I'm still not sure what to make out of it. It looks like, some old-time flyer in a flying helmet, but then when you look closely, it's like, geez, wait a second, those are trees, and you start looking at that, is that eye, is that a golf ball? And it's like, it doesn't make any sense. Okay? Here's a series of pictures that were painted by a person going through a schizophrenic episode. And schizophrenia, like depression and bipolar disorder, is actually kind of episodic in that we'll cycle through. So we see this nice cat picture up here in the upper left-hand corner while they're in that kind of the normal phase. And then as they begin to slip off to hallucinate, now when we've asked them to draw a cat, it's like, wow, what's going on here? And then as it progresses, it's starting really to lose, touch with reality, and we're really beginning to hallucinate. And you can see, this very abstract form back here. And as we move through severe and we start to cycle out, and you can say, when we're starting to come back, over here it's like, oh my gosh, what is this? And here it actually looks more like an owl to me than that of a cat. But as we cycle back out, eventually we'll come back to painting things like this. And people will go through these episodes. And people who develop schizophrenia, as we'll see, the prognosis is not all that good. And they are going to cycle in and out of these. The one advantage is that we can use antipsychotic drugs and some other chemicals to try to keep them in check and minimize the amount of hallucinations and delusions they have, and try to keep them as much within reality. But the notion that they're all violent and potential serial murders is way overplayed in TV and the movies. Here, come back to Vincent van Gogh, and one of the things here, if you look at the two paintings down below, the one up in the upper right-hand corner, by the way, is a self-portrait that Vincent van Gogh did of himself. But the two paintings down below show you a stark contrast in his painting style. The one on the left, which is one of my favorite pieces by Van Gogh, is the Cafe at Night. And look at the detail, and you can very clearly see the street scene and the figures and things like that. And then you come over the Starry Night, and it's like, my gosh, what's going on here? It's kind of like, what drugs was he on when he did this? What perception the world did he have? And, stark contrast. And that's where we knew that he suffered from psychotic bouts. And people historically have been going back and trying to figure out what was it. And, a lot of people thought it was schizophrenia because of this drastic change here. And this was in the period where the schizophrenia is really flaring up and a lot of hallucinations. And here he is in his schizophrenic cycle, very much in grasp of reality. What we actually come to find out, though, that in studying him in more detail, we learned that when he had these bouts and he painted things like Starry, Starry Night, yes, he was suffering from delusions and hallucinations during this period. But unique in this situation is he had absolutely zero recall. Now, that is not typical of a schizophrenic patient. They generally will recall the things that they did during their schizophrenic episode. So it has us actually now turning and looking at seizure activity, and that very likely he had an advanced form of epilepsy and was suffering from these epileptic seizures, and would have these massive rush of neurotransmitters in the brain, would bring about the hallucinations and the delusions, which would lead him into this period. And some of these seizures and their after effects may last for weeks on end, and thus we get paintings like Starry, Starry Night. And when he was not enduring any seizures, we get Cafe at Night. And so this is one of the things here. We do know that for sure that Vincent van Gogh suffered from depression, and in one particular point in his life where he was very depressed, where a close friend left him, he actually cut off his own right ear. And this actually, he did it during one of these psychotic episodes. And this is actually a painting that he did another self-portrait of him. This is a self-portrait about 2 weeks later, as he's coming out of the bout of depression and he's settling down. There's, the epilepsy has worn off. And he painted this very coherent picture of him with a, bandage around his head where he had literally severed his left ear. And that. What's really interesting about Vincent van Gogh, he's one of the most famous painters that we have, particularly in the Impressionistic period back then. But during his lifetime, he really wasn't given much credit for being a master. About several months after he committed suicide, that he actually was acknowledged by the art world as one of the great masters of painting. And but he basically was living hand in hand from one little pay thing for a painting to another. He literally was the starving artist, which probably didn't help his depression nor his epileptic seizure periods. Okay, from there, just to finish this off as we're coming back and talking, is that we believe that some of this disorganization and delusional thinking is due to a lack of selective attention. They just can't, they pick up on whatever thought rushes through their mind, they grab it, but they can't hold on to it, can't focus on it. Okay, our third feature is inappropriate emotions and actions. In relationship to schizophrenia, some people may laugh at news of somebody dying or show no emotion at all to such news, and that is what we refer to as flat affect. Now, obviously, the first part is inappropriate affect, and this is flat affect. On the action side, some patients who suffer from schizophrenia will maybe continually rub an arm, rock a chair. You almost kind of look at it as autistic behavior that we talked about back in development that kids go through. Or they may just remain motionless for hours, and this is what we refer to as catatonia, or a catatonic state. And literally it's kind of like, somebody going up to R2-D2 and just pulling the plug on the robot, and the robot just kind of stops whatever it's doing and just goes off into kind of a blank stare. And it's literally what schizophrenics will do. They'll become very rigid. They could be sitting in a chair. They could be standing up. You can rub your hands in front of their face back and forth. And they just it's like somebody pulled their plug. And what we believe is that their inner thoughts, their hallucinatory mind and delusions become so powerful that it pulls them out of reality and into their own internal mind, and where reality around them is not stimulating enough, and the internal world is far more stimulating, and so that is what they focus on. Okay, when we look at symptoms, schizophrenia generally starts off with where an individual will show signs of irritability, tension, they'll have difficulty sleeping and difficulty concentrating. And that's where we start to see this beginning of the lack of selective attention coming in. They can't concentrate, they can't focus, they're starting to surf from thought to thought to thought, whatever pops into their mind. As it progresses, they'll have a lack of emotion. They may move into that flat effect. They don't get extremely happy. They don't get extremely sad. They're just kind of flat, and therefore they don't show proper emotion. Strongly held beliefs that are not based in reality start to suffer from delusions. And then they have those false sensory sensations, such as hearing things, seeing things, that we refer to as hallucinations. Okay? So to test, you want to be able to distinguish between a delusion and hallucination. So delusions are what they think of themselves. They think of them as Mary Poppins, Jesus Christ, something like that. Then you're dealing with a delusion. If it is a sensory experience, they hear, they see, they touch, they smell something that doesn't exist, then that is a hallucination. Okay? They have problems then paying attention. Their thoughts often jump to unrelated topics. Once again, that channel surfing. Bizarre behaviors will come about, and they'll do some really weird things during this period of time because they're not focused in reality. And they also will be characterized by social isolation, which might lead some people to think, well, gosh, they're depressed. Now, there can be a comorbidity diagnosis, comorbidity being a fancy term for we diagnosed you with one disorder and there's another disorder running along with it. And we will see comorbidity with schizophrenia. Sometimes we'll see depression. More often than not, a lot of times we'll see alcoholism, drug abuse. In the case of Vincent van Gogh, he used to drink this anise-flavored alcohol that was just, like rocket fuel, which probably didn't help at all his epileptic seizures or anything, and probably caused him more to relapse than to escape it. But probably because of everything that was going on, he wanted to escape those, epileptic, moments, and probably drinking the alcohol only encouraged them more. So, unfortunate for him. Types of schizophrenia, we actually have 3 subtypes of schizophrenia. The first one is a paranoid schizophrenic. And person is anxious, they're angry, they're argumentative, and they also oftentimes have false beliefs that other people are trying to hurt them or their loved ones. And in this case, because they can be angry and argumentative, they may actually strike out. And the paranoid schizophrenic is probably the one type of schizophrenic that when you're around, you have to be concerned whether they might strike out, either, vocally or physically. And that Sirhan, who shot Bobby Kennedy years ago, was believed to be somewhere between paranoid schizophrenic and paranoid personality disorder. But, he thought that Kennedy, if he became elected, was going to lead to the end of his life. And so he came here and he killed Kennedy before Kennedy could be elected president. Catatonic schizophrenia is, where we go into that catatonia, the catatonic state. So we have people that are characterized by lack of activity, the muscle, posture, may become rigid here. They grimace a lot, making really odd expressions with their face, or they do not respond much at all to people. And that sometimes they just get in, they're kind of really motionless and they grimace, and then sometimes they're just flat. They don't respond at all to people. The third major subtype is disorganized schizophrenia, and this is where it's kind of no fun. I mean, their hallucinations and their delusions are, kind of like a tossed salad. They're not complete. They're Jesus Christ, but it's not holding up. And then there's somebody else, and then there's somebody else. We had a guy when I worked in the bars in Chicago, down on Rush Street, who used to walk around carrying a big, huge cross and dressed like Jesus Christ. And you'd stand out there in the street corner and he'd be preaching and you'd come up and ask him questions. And man, he had it together. His delusion of being Jesus Christ was incredible, and it was almost impossible to trip him up. And in fact, I never saw anybody actually trip him up. He always kept talking about his Father. He had all the preachings down, all the sermons down, and everything else. And that guy had it going as far as a delusional behavior. However, in the disorganized one, their delusions are not going to be any fun. They're not going to be unified. And that's what happens here. Sometimes we used to refer to disorganized schizophrenic as a hebephrenic schizophrenic, which meant that it was just, they're a mess. And probably the worst type of schizophrenia to suffer from. From there, we have just a couple others. We have the undifferentiated, which means they show a little bit of everything, but nothing of one in particular. And so undifferentiated means, well, we can't tell the difference. So we use undifferentiated. This is a classification that we're probably going to see fade in the DSM-5 because it's overused. And I think they're going to make psychologists say, okay, if you're going to call this schizophrenia, you got to pick one. You just can't go with this undifferentiated. The last one is residual schizophrenia, and this is after somebody has gone through either a schizophrenic episode or maybe who has not had a full-blown one. And maybe, it's kind of left over from prior schizophrenic episodes, show some of the behaviors of their particular episode, but it's very, very mild, and we'll call that then residual. So, okay. Let's take a look at the onset and development of schizophrenia. First off, it is believed that it's as prevalent as 1 in 100 people suffering from schizophrenia, and the World Health Organization back in 2002 estimated that as many as 24 million people around the world are suffering from schizophrenia. As we had noted earlier, schizophrenia and depression are the two most prevalent disorders that we find in almost every culture around the world. And so this one is very real, just as depression is, and very pervasive around the world. Another characteristic of it is that it generally strikes young, usually in adolescence. We have some measures to try to pick it up in childhood, and a little bit questionable just how early it begins, but definitely in adolescence we'll see the development of schizophrenia and those early behaviors starting to come in. Really sets in during adolescence, early 20s. And essentially, if you haven't developed schizophrenia by the age of 35, you're probably free and clear of ever developing it. It does have an early onset and very rarely will come in middle adulthood or later adulthood. In relationship to men and women, it's an equal opportunity disorder here. Affects men and women equally, but men suffer from it more severely than women for some reason. Men get it much more intensely. Okay. When we look at chronic and acute, chronic meaning very severe, acute meaning lesser. The chronic usually comes a slow development, slowly from our adolescence it builds up steam into our young adulthood, and then, later on into that, young adulthood, 25, 30 years of age. When it has that slow kind of what we call process development, it is very doubtful that we will ever recover from it. And generally the symptoms that will develop with it we refer to as negative symptoms, like hallucinations, delusions, and some of the more severe psychotic behaviors, because they're very difficult to treat. And we have a very difficult time getting rid of those types of behaviors. On the acute side, or the lesser side of it, it generally is where it develops very quickly, kind of a rapid progression, maybe reaction to some extreme traumatic event in our life. And in this case, recovery is better. So the quicker the onset of it, the real fast onset, kind of comes out of the blue, we got a better chance of treating that than that long, steady, slow, rapid buildup and that. And generally with the acute schizophrenia, we'll usually see positive symptoms, which means that they're different from what we have in normal life. They're definitely kind of abnormal behaviors, but they're generally things that will respond well to the use of antipsychotic drugs and things like that, and we can very much minimize the effects of schizophrenia in that type of individual. Okay, when we look at schizophrenia, we believe that it's related to brain abnormalities, and we have some pretty good research on it. First off, dopamine, which is, one of our stars of the show here, neurotransmitters that we've talked about many times, and that, but we talked about is that essentially excessive levels of dopamine leads to schizophrenia, and we find that basically the dopamine D4 receptors in the brain, produce a tremendous amount of dopamine and they allow it to come in, and so we believe that this is related. Remember that lesser amounts of dopamine when the brain is underproducing leads to Parkinson's disease. And so anyways, we have that one connection. Here we're looking at where in the brain is actually affected, and it affects the frontal cortex, the thalamus, and the amygdala. In schizophrenics, here we have a young brain with normal tissue, and what we're looking at is tissue loss. Okay, the notion is that pretty much once we get to around the age 15, 16 years of age, we stop producing new brain tissue, so we're going to have some loss. But here we can see in this picture very minimal loss, in that a lot of purple up in here, with either representing 0% or maybe somewhere between 1 or 2%. Here we have a little bit more active loss of tissue. However, in the schizophrenic's brain, in the adolescents, look at the severe tissue loss that we see in these particular areas here. Just a dramatic difference in tissue loss. So something is going on up here, and we're not still quite sure what it may be. We think that it could be viral, in the sense that related to some virus that attacks the body and particularly affects the brain. We have seen in the difference between a non-schizophrenic and schizophrenic brain is an increase in fluid in the brain, indicated by this larger chamber here. And as we noted, it may be produced by some virus or influenza, or maybe it's our immune system that basically is attacking this, and what we call autoimmune disease, where the immune system kicks in to fight a virus, it doesn't kick out, and thus we get adverse effects. Then these are all things that we're studying at this time. So while we have some pretty good hunches what's going on, we can't explain why, or we can't explain what we see or why we see it. Schizophrenia is often linked to maybe viral infections while the mother is carrying the baby in the womb, particularly during the middle of the fetal development cycle. And so that's one of the things. And looking at people who suffer from schizophrenia, going back, doing extensive histories and looking at correlational research, we find that a lot of them, report, that their mothers had a viral infection of some sort during pregnancy. And it seems to be a tendency more towards the middle when they have this viral infection is linked to schizophrenia as opposed to earlier or late in the pregnancy cycle. So when we look at the genetic factor, you can see that genetics stack up here pretty well. Identical twins, around 50-55%. If both parents have schizophrenia, not good news. You probably got about 47 to 50% probability. Fraternal twins really drops off, which is really interesting. And then one parent having it drops off more. Sibling have it, drops off more. get down to a nephew or niece, and well, about a 3%. So yeah, runs in the family gene pool, but not very strong there. And if somebody is unrelated to you, they have schizophrenia, what's the probability of you having? Well, there actually is a small statistical probability, but very low. Here's one of those slides where you can go and kind of knock your socks off looking at all the different possibilities. It's a little bit more extensive. I'll let you look at it here for a second before I move on to the next slide. Okay. Here's another one that's kind of interesting. When we look at the risk of schizophrenia amongst twins in different countries, and you would say, gosh, if it's genetic, it should be pretty stable. But look at the ups and downs that we have between identical twins from country to country, and then fraternal. But I think the dramatic thing is, look at Germany. My gosh, if you got an identical twin in Germany, look how high the probability of you developing schizophrenia. I'm going to take Denmark or the UK preferably, because there you got the lowest percentage. But the question is for us to try to figure out, we see these statistics, but why do they vary? And it brings in environmental influences. There's something in the German environment that may trigger this in individuals as opposed to UK or Denmark. Here we see a picture of 4 sisters in a relatively famous family where all 4 of them had schizophrenia, but 2 of them had much more severe cases than the other 2. And once again, this kind of points back to the environmental. Yes, it runs in the family. You think if it was solely genetic, they probably should all be affected equally. However, not, which may mean that there are environmental factors that contribute to this as well. Okay. On the treatment side, what do? We primarily use antipsychotic medications. They're most effective for treating schizophrenia. They help change the balance of chemicals in the brain, primarily focusing in on that dopamine imbalance. What the negative side of it is, though, that antipsychotics used over a period of time can have many negative effects. It can interfere with our ability to sleep at night. Can make us dizzy or disoriented during the day. Not good. Can't drive a car. Can cause weight gain. Increased chances of diabetes and high cholesterol. A couple things that can kill you. Feelings of restlessness or jitters during the day. Maybe slow our movements down. You feel jittery, but you just can't get it into gear. And then can produce tremors. So not really positive side effects there. And this is from sustained long-term use. But one of the things is we're going to see here when we look at the prognosis is schizophrenia seems to be a lifelong disease. And in order to treat it, we're going to have to keep a person on psychotics, antipsychotics. Okay? The more major concern is that long-term medication on antipsychotics leads to an increased risk of a physical disorder that we refer to as tardive or dyskinesia. And this essentially is what it causes repeated movements that you can't control, especially around the mouth. But over time, it can affect our motor movements throughout the body over a longer period of time, which can lead to dysrhythmia of the heart, and can lead to malfunctioning of the lungs, and obviously you can see nothing good is going to come out of that. The prognosis, as I said, it is a lifelong illness. Most people with this condition will need to stay on antipsychotics medications for the rest of their life. One thing that we try to do with them is alter medication, switch it up. There are some antipsychotic drugs, and there are some other drugs that we can substitute in. Try to raise and lower the dosage depending on where you are and kind of the cycle of schizophrenia to try to manage it better and that. But it is one of those things, though, that if you don't take the medication, very likely the more major concerns about, changes in behavior, and hallucinations and delusions are going to come back if you don't take the drug. Okay, and that wraps up part 5.